there, I'm John, and welcome to the Chronicle of Medical Surgical Nursing. So, I'm here again giving lectures about some concepts in medical surgical nursing that will help you as you will take any foreign or local nursing qualifying examination. So, I'll be talking about requested topics from my Facebook friends. So, for this clip, I'll be talking about vascular disturbances. I'll be talking about anticoagulant and antiplatelets, as well as a portion of your mechanical ventilator. Okay, so the entire concept, the entire discussion can be seen, okay, actually in the book The Chronicle of Medical Surgical Nursing. So this is just somehow a supplementary video clip for the topics I mentioned. So let's start. So let's talk about vascular abnormalities or vascular problem. Remember, the vascular compartment is actually a closed circuit, correct? It is a closed circuit connected, okay, actually from the heart. If you can still remember, okay, now if this is your heart, we know that your heart is divided into two sides, right? Now, the right side of the heart and the left side of the heart. Remember, the right side of the heart receives and pumps unoxygenated blood. The left side of the heart receives and pumps oxygenated blood. Now remember, when the heart pumps the blood out, okay, when the heart pumps the blood out, the blood enters a closed circuit, and that closed circuit is what we call blood vessel. Remember, our blood vessels are actually divided into three. Okay, there are three types of blood vessels. The first blood vessel is a blood vessel connected on the left side of the heart, and that blood vessel is what we call an artery. Okay, a small artery is what we call arteriole. Whereas another blood vessel, okay, there's another blood vessel connected on the right side of the heart. That blood vessel connected on the right side of the heart is what we call vein. Remember that a small vein is what we call venule. The last type of blood vessel is very small, okay, it has a very thin membrane, and this is the blood vessel that connects, that joins the artery and vein, or shall I say, arteriole and venule. That blood vessel is what we call capillary. Can you follow? That blood vessel is what we call capillary. Now remember, if the left side of the heart pumps oxygenated blood, that blood that contains oxygen enters an artery. That is why when you say artery, an artery is a blood vessel that contains or carries blood rich in oxygen away from the heart. Remember, artery away from the heart. When that oxygenated blood enters an artery, it enters a small portion called arteriole until such time that blood passes the capillary area. Remember, I mentioned a while ago that capillary has a very thin membrane. Because of its characteristic, the membrane is so permeable to the point that as the blood passes through, the oxygen inside the blood diffuses. Remember? Remember diffusion. There's movement of molecules from a higher concentration to a lower concentration. That is why, when blood passes the capillary area, the oxygen that it carries will diffuse. It goes to your cells here. Remember, we call this as a form of what we call internal respiration. Therefore, when the blood reaches on the other side, remember on the right side where the veins are, it is now a blood less oxygen content. In short, a vein carries unoxygenated blood or deoxygenated blood back to the heart. Can you follow? So please do not forget the blood flow. Okay? Now remember, when I say vascular abnormalities or vascular problem, a vascular problem may affect veins of the patient, right? Or a vascular problem may affect arterial of the patient. Now, the thing you need to remember in your examination here is that what will you do as a nurse? How will you position the patient if the patient suffers from venous obstruction or venous problem? How will you position the patient if the patient suffers arterial occlusion or arterial problem? Because these two blood vessels are different, right? Now, what specific blood vessel problem wherein there is a low perfusion and a high perfusion? Let's analyze. If you're going to divide this one, this is the right side and this is the left side. Remember, right side, that's your vein. And in your vein, it carries unoxygenated blood back to the heart. Am I right? On the left side is are your arteries. Remember, an artery carries oxygenated blood away from the heart. Therefore, if a patient suffers from arterial occlusion or arterial problem. Let me give an example of a condition that affects the artery. Example, patient having Raynaud's phenomenon or Raynaud's problem or Raynaud's disease, or patient having thromboangiitis obliterans, or you call it a Scherberger's disease. So a patient with those conditions, remember, they affect arteries or arterial line. That is why if arteries are affected, the blood flow to your vital organs are also disrupted. That is why if there is occlusion in the artery, there will be decrease. There will be decreased perfusion or a low perfusion. Are you with me? But for patient with venous obstruction or problem in the veins of the patient, if there is problem with the veins, there is a hard time now for the blood, okay, to go back to the heart. In short, there's problem with the venous flow. Am I right? So therefore, if there's problem with the veins of the patient, there is a hard time for the blood to go back to the heart. As a result, the blood now will pool in the lower extremities or in the lower part of the body, resulting to an increase in what we call perfusion. Are you with me? So please do not forget this. Arterial problem will give you low perfusion. Venous problem will give you high perfusion. That is why a patient with arterial problem, because of a decrease in the perfusion, if you try to feel the skin of the patient, the skin is actually cold to touch. Am I right? For patient with venous obstruction, if you try to feel the skin of the patient because of increased perfusion, there's pulling. If you try to feel the skin of the patient, it is warm skin to touch. Am I right? One more thing. Because of problem in the circulation, particularly in the artery, blood flow, if you try to feel the pulse of the patient, there it will be weak pulse. Can you follow? Weak or thready pulse. But for patient with venous obstruction because of congestion, expected that there will be strong bounding pulse. Strong, pulse. Now question, knowing, that venous problem will give you high perfusion and arterial problem will give you low perfusion, how will you position the patient? That is why, I formulated a new mnemonic for this one, and I will name that as your Dave. Can you follow? So don't forget Dave. Dave stands for dangle artery, vein elevate. In short, a patient with a problem in the artery, you need to dangle. Can you follow? Why will you dangle, the affected part if it is arterial problem? To promote circulation. Because remember, in an artery, the direction of your blood flow is away from the heart. But for patient with venous problem, because there is a hard time for the blood to go back to the heart, what will you do as a nurse? You elevate the extremity or elevate the affected part. The reason why you elevate is to promote venous return. Are you with me? So please do not forget that. So that is what we call vascular problem. Okay, so specific discussion of the vascular abnormalities is actually in the book The Chronicle of Medical Surgical Nursing. There I discuss the different types of aneurysm. I talk about DVT, I talk about Raynaud's disease, and a lot more. So I want you to read the textbook because it's all in there. Okay, so this is just a supplementary video presentation. Now another thing is actually your anticoagulant and antiplatelet. This is actually a highlight in your examination, right? Anticoagulant and then your antiplatelet drug. Now let's start with what we call antiplatelet. Now, sir, question. What is the difference between an antiplatelet drug and an anticoagulant? What is the difference between an antiplatelet drug and an anticoagulant? When you say antiplatelet, when you say an antiplatelet drug, it is an agent that prevents platelet to form a clot. It prevents platelet to form a clot. Now when you say an anticoagulant, anticoagulant on the other hand is an agent that prevents clot. It prevents clot. Did you get the difference? When you say antiplatelet, it prevents the platelet to form a clot. When you say an anticoagulant, it prevents clot formation. These two is also different. When you talk about thrombolytic drugs. Thrombolytics are drugs that will dissolve the clot. Did you get the difference? Anticoagulant prevents clot. Antiplatelet prevents platelet to form a clot. Thrombolytics will dissolve the clot. These three drugs, okay, these three agents, antiplatelet, anticoagulant, thrombolytics, they can cause bleeding. That is why patient receiving these agents, you have to watch out for bleeding tendencies. Okay, so let's start with your antiplatelet. Now, one good example of an antiplatelet drug, okay, is what we call aspirin. Remember aspirin? Aspirin has actually a lot of classifications, right? An aspirin could be an analgesic drug. An aspirin is also antipyretic. And as mentioned, aspirin is also an antiplatelet. Correct? It is also an antiplatelet. Now, thing to remember about aspirin is that aspirin is actually gastric irritant. So, as a nurse, if the agent is gastric irritant, we know that this must be taken in full stomach, right? Now, since aspirin is an antiplatelet, okay, remember there is what we call bleeding tendencies. Okay, now the question here in your examination will be, when will you discontinue aspirin prior to surgery? Or when will you discontinue aspirin prior to invasive procedure because of bleeding problem? The answer is that you have to discontinue aspirin at least 2 days or 48 hours prior to surgery. Do not forget that. Okay? Discontinue aspirin at least 2 days, or shall I say 48 hours prior to surgery. Am I right? So this is what we call your aspirin. Now, what do you think is the best test to evaluate therapeutic level of your aspirin? Actually, in the book, to check therapeutic level or therapeutic effect of your aspirin, one test is to check for the platelet concentrate level or the platelet count of the patient. Okay? Now, do we have overdosage of aspirin? Yes, we do have overdosage of aspirin. So what do you think is the antidote for aspirin overdosage or aspirin toxicity? Well, there is no specific agent that can be given to your patient, but patient with overdosage of aspirin or aspirin toxicity may be given activated charcoal or may be given sodium bicarbonate. Okay? So that is what we call your aspirin. Next, another is what we call your anticoagulant. Anticoagulant. Now, one good example of an anticoagulant, number one, is what we call your heparin. Am I right? The heparin is an anticoagulant. I can still remember this thing came out in the local board examination here in the Philippines. The question there, can you give heparin to pregnant? What do you think is the answer? Can we give heparin? Of course. Heparin may be given, okay, may be given to pregnant because heparin cannot pass the placenta. Okay? Another thing to remember. When you say heparin, what do you think is the route or route of heparin administration? Heparin is actually given parenteral. What specific route of parenteral? Okay, that will be given intravascularly. But remember, there is a low molecular type of heparin. Okay? And that type of low molecular heparin can only be given subcutaneously. What do you call that low molecular heparin given sub-Q? Answer, that is what they call enoxaparin. So please be reminded, enoxaparin will be given subcutaneously. It is a low molecular type of heparin. Clear? Next, if your patient is receiving heparin, what do you think is the best diagnostic test that will evaluate its therapeutic level? Now remember, there are two possible answers here. What do you think is the first answer and the second answer? The first answer, technique. Heparin starts on what letter? Heparin starts on letter H. Am I right? Heparin starts on letter H. If you put P prior to H, it looks like what? PTT. Familiar? So what does PTT stand for? PTT stands for partial thromboplastin time. Therefore, the first answer, the best test to evaluate therapeutic level of heparin is your PTT or APTT. Can you follow? Question, what do you think is the normal PTT count? Or what is the normal PTT level? The normal is actually 20 to 36 seconds. Can you follow? 20 to 36 seconds. Now, What if you cannot find PTT in the given option? The next answer, if you cannot find PTT, is actually your clotting time. Okay? Remember, if you cannot find PTT, the next answer is your clotting time. Question, what is the normal clotting time? The normal clotting time is actually 5 to 10 minutes. Remember, these are their normal levels. But let me remind you, if your patient is taking anticoagulant heparin, there is a specific therapeutic level. And if the patient is within the therapeutic level, it's okay. Now, thing to remember, the therapeutic level is actually 2 to 2.5 times higher than the normal range. Therefore, what do you think is the therapeutic level? Okay, what do you think is the therapeutic level of your partial thromboplastin time, or PTT? The therapeutic level is actually 60 to 80 seconds. Now, what about the clotting time? Therapeutic level is 16 to 20 minutes. Okay, please do not forget this one. This is a highlight in your exam. Again, the therapeutic level is usually 2 to 2.5 times higher than the normal range. That's your diagnostic test. Next, third question. What if the patient is scheduled for a surgery or invasive procedure? What do you think, okay, or when do you think is the best time to discontinue heparin? Now remember, the best time to discontinue heparin is a day prior to surgery. Can you follow? So discontinue that one day prior to surgery. A day prior to surgery. Now, if the patient develops overdosage of heparin, okay, if patient develops overdosage of heparin, what do you think is the antidote? I can hear the answer now. The antidote is sure, very good. The antidote is sure, protamine sulfate. Protamine sulfate. Now, just an additional input. Protamine sulfate is an agent actually derived from, okay, it is an agent derived from fish sperm cell. Okay, fish sperm cell. Just an additional input. Okay, so that is what we call your heparin. Now, hold on. Pinagpapawisan ako. Give me a few seconds. Okay, I'm back. So that is what we call your heparin. Okay, that's your anticoagulant. Another anticoagulant, number 2. Okay, number 2. Another anticoagulant is what we call your warfarin. Warfarin. You also call this a comedine. Comedine drug. Now, question. Can we give warfarin to pregnant? No. Not for pregnant. Okay? Now, if heparin is actually given parenteral, now what about warfarin? Warfarin is actually given per oram. It's PO. Okay? Next, if your patient is receiving warfarin, okay, when do you think is the best time to discontinue warfarin prior to surgery or prior to an invasive procedure? Technique. Warfarin starts on letter W, right? So you have to discontinue warfarin 1 week. That's W, okay? A week prior to surgery. So discontinue 1 week prior, okay, to surgery. Another thing, if your patient is receiving warfarin, what do you think is the best diagnostic test that will evaluate its therapeutic level? Okay? What do you think is the best diagnostic test that will evaluate its therapeutic level? Again, we have 2 possible answers. What is the first answer and the second answer? The first answer is actually PT. That's your prothrombin time. What do you think is the normal level or the normal range for your prothrombin time? It is your 9 to 12 seconds. Okay? 9 to 12 seconds. Now, what about if you cannot find PT or prothrombin time? What is your second possible answer? The second possible answer is actually your INR. Okay? So what is the normal INR? The normal is 2 to 3. Can you follow? Just like what I've said a while ago with your heparin, there is a specific therapeutic level. And I said the therapeutic level is actually 2 to 2.5 times higher than the normal level or the normal range. Therefore, what do you think is the therapeutic level, okay, of your PT, of your INR, if your patient is taking warfarin? Let's start with your PT or prothrombin time. The therapeutic level of your PT or prothrombin time, it must be less than 30 seconds. Can you follow? Now, what about your INR? Okay, the therapeutic level of your INR, it must be what? Less than, okay, 4.5. Clear? So please be reminded of the therapeutic level of the different tests. Okay, and of course, a specific agent, maybe heparin or warfarin. Follow-up question. If your patient is taking warfarin, what do you think is the antidote of warfarin toxicity? The antidote, okay, the antidote is actually your vitamin K. Am I right? We also call vitamin K as your menadion or menadion or mephiton or aquamephiton. Question. When you give vitamin K, do you think it will start its effect immediately? No, it takes 24 hours to effect. Now, since I mentioned vitamin K, and vitamin K is the antidote for warfarin, remember, green leafy vegetables, they contain vitamin K. Therefore, common sense will tell us if your patient is on warfarin treatment, okay, warfarin treatment, avoid eating green leafy vegetables because it will defeat the purpose of warfarin, warfarin treatment. Am I right? So these are the different anticoagulants you need to remember. Remember, antiplatelet, that is your aspirin. Anticoagulant, you have your heparin, and you also have your warfarin. So these are common drugs, okay, you need to remember in your exam because these are actually common questions in your qualifying exam, okay? Okay, let's proceed. The third and the last concept requested on Facebook. It's your mechanical ventilator, it's your MV. Okay? Your mechanical ventilator is actually the machine itself, okay? The machine itself delivers air to your patient, okay? So long time ago, a mechanical ventilator machine is actually a negative pressured machine. Okay, but nowadays, okay, now the recent mechanical vent are actually positive pressured machine. So what do you mean by that? In short, if this is your mechanical ventilator and it is a positive pressured machine, it means to say, let's say, please bear with my drawing. Let's say this is your patient, okay, hooked in a neck vent. In short, if a neck vent is a positive pressured machine, it means to say that the machine pushes air to get inside the lungs of the patient, right? So when you say positive pressured machine, it gives air, okay? It gives air. So the machine delivers, the machine pushes, the machine gives air to your patient. Now, okay, on Facebook, there's a question about BiPAP and then your CPAP. Am I right? So what do you mean when you say CPAP? What do you mean when you say BiPAP? Now your CPAP stands for continuous positive airway pressure. Okay? Continuous positive airway pressure. When you say BiPAP, it's your bi-level. When you say bi, that's 2. Okay? So your bi-level positive airway pressure. Okay? Remember, these 2 are actually set up in your neck vent. Am I right? Now, so these 2 delivers positive airway pressure. Now, what is the difference between your CPAP and your BiPAP? Now, let's start with your CPAP. Let's say this is the patient. Oh my God. Please bear with my drawing. Okay, let's say this is the patient. Okay, this is your patient. When you say CPAP or continuous positive airway pressure, it means to say that the machine delivers a positive pressure continuously. Can you follow? Continuously. Ibig sabihin, even when you inhale, even when you exhale, there is a positive pressure coming in. Clear? Now, the question, what is the pressure? The pressure is constant. The pressure given during inhalation will be the same pressure delivered during exhalation. Let me give an example. Just an example. Let's say the machine is actually set up into CPAP and let's say the pressure is 20 centimeters water. This is just an example. So when I inhale, the machine pushes the air to get inside my lungs, and it delivers a pressure of 21 centimeters water. When I exhale, still the machine pushes air to get inside. Can you follow? So there's a continuous delivery of air even if you exhale. Now, when is your CPAP indicated? Usually CPAP is indicated to patients with obstructive sleep apnea. The main purpose of this is to maintain that the airway of the patient is open. Can you follow? Because when you exhale, still there's air coming in, right? The problem with your CPAP is that there's the feeling of the patient like drowning. Because even if you exhale, okay, air is getting out from your lungs, okay, the machine pushes air back because there's a positive pressure. That's your CPAP. When you say BiPAP, okay, or bi-level positive airway pressure, okay, the pressure delivered during inhalation is different from the pressure given during exhalation. Usually, the pressure during exhalation is lesser than the pressure during inhalation. Let's say, during inhalation, the machine delivers 21 centimeters water when you inhale. But when you exhale, okay, the pressure delivered by the machine decreases. Instead of delivering it at 20, let's say it's less than 20. But still, it is continuous. Still, it is a positive pressure, but of two different pressures. In your continuous positive airway pressure, or your CPAP, the pressure delivered during inhalation and exhalation are the same. And the pressure, okay, was actually given continuously. In your BiPAP, okay, the machine delivers a positive airway pressure, but of two different pressures. One pressure for your inhalation and the pressure during exhalation are different. That's your BiPAP. Okay? Now, in your examination, the thing to remember about your neck vent are actually the alarms. Hold on. Pinagpapawisan na naman. Okay, I'm back. In your neck vent, okay, one thing to remember in your examination are actually the alarms. Okay? There are three common alarms in your neck vent. Okay? There are three common alarms. The first alarm in your neck vent is what they call the high pressure alarm. The second alarm in your neck vent is your low pressure alarm. And the third common alarm in your neck vent is what they call your apnea alarm. Okay? Apnea alarm. Now, question. Okay, when you say high pressure alarm, when is this alarm being activated? High pressure alarm is activated if there is what they call obstruction. Or, shall I say, there is resistance. Okay? When you say low pressure alarm, this is usually activated if there is what they call leakage. Or, if there is loose connection. Apnea alarm is usually activated if you try to wean the patient. Can you follow? Or, there is what they call accident, okay, extubation, or accident what? Detachment of the interface to your machine. Okay, let me give an example. Now let's start with your high pressure alarm. Remember I said that this is the machine, right? And this is our patient. Better. I said that the machine delivers air to your patient. Remember, it is a positive pressured machine. Now, when you say high pressure alarm is activated if there is obstruction or resistance. Let me give an example. Let's say that the lungs of the patient, the airway of the patient is filled with mucus. There's too much phlegm. In short, if the lungs of the patient, if the lungs or the airway of the patient has a lot of secretions, those secretions can cause airway obstruction. Am I right? For example, this is the airway, and the airway is filled with a lot of mucus. It causes obstruction. Because of the obstruction, what will happen? The machine now, will exert a high pressure. Will use a high pressure to push the air to get inside the lungs because of the fact that there is obstruction in the airway brought about by mucus accumulation or mucus plug. That is why high pressure is activated. Again, high pressure alarm is activated when the machine uses a high pressure to push the air to get inside the lungs because there is obstruction or there is what we call resistance. So question, if that condition happens, what will you do as a nurse? Of course, what will you? You suction the patient. Am I right? And when you say suctioning, that is another highlight in your exam. Am I right? So when you say suctioning, what should be the duration of your suction? Am I right? Okay, how will you apply suction? Is it continuous suction or intermittent suction? What is your priority prior to suctioning? Right? So that can be seen in the in the Chronicle of Medical Surgical textbook, right? The thing I wrote. So you have to read the entire book, okay, to better understand the concept. Okay. Now another example of high pressure alarm activation is that if the patient is awake and the patient is intubated but the patient is awake, remember there are times that the patient will bite the ET tube or the endotracheal tube. Remember, the moment you bite the tube, there is what we call obstruction or resistance. So again, high pressure alarm is activated. So what will you do? Will you suction the patient? No, you tell the patient, okay, do not bite the tube. Okay? Or if not, we sedate the patient upon doctor's order. Right? Now, another example of high pressure alarm activation is actually the corrugated tube. Remember, I hope you are familiar with the corrugated tube. Remember, okay, the corrugated tube comes in semi-transparent white or semi-transparent blue, right? But in the corrugated tube, what will you notice inside the corrugated tube? Moist. Am I right? And eventually, that moist turns into water, right? Therefore, if the corrugated tube is filled with water, will that cause obstruction? Yes. Will that activate high pressure alarm? Yes. Will you suction the patient? No. What will you do? You detach the tube and dump the water out, right? So after dumping the water out and reconnect the tube, the high pressure alarm will be what? Corrected. So bottom line, when you say high pressure alarm, there is obstruction, there is resistance. Either you suction the patient or you check the connections. Okay? Now, what about low pressure alarm? Low pressure alarm is activated if there is leakage or loose connection. In short, if there is what we call leakage in the tubing or interface of the patient, let's say there's a hole, there's a leakage, the machine pushes air to get inside the lungs. But because of loose connections, because of leakage, there is no pressure, or shall I say, the machine is not having a hard time to push the air to get inside the lungs of the patient because of the fact that there is leakage. In short, the machine will use a low pressure, somehow effortless, okay, less pressure, okay, because of leakage or what we call loose connection. So what will you do if low pressure alarm is activated? Will you suction the patient? No. What will you do? You check the connections. Can you follow? So this is your low pressure alarm. Next, apnea alarm. When you say apnea, apnea is a medical term that describes absence of breathing or absence of respiration. Apnea alarm is activated usually if you try to wean the patient. Remember, when you wean the patient, sometimes we detach the patient from the neck vent, right? We detach the patient from the neck vent and evaluate whether the patient can breathe on his own. That's your weaning. Or, if not, there is accidental extubation or there's accident detachment of the interface from the machine. Therefore, if accidentally, okay, there is accidental extubation, nobody now is breathing through the machine. If nobody is breathing through the machine, that can be assessed by the machine as apnea, absence of respiration, because nobody is being hooked in the machine. Therefore, apnea alarm is activated. Okay? So these are the three common types of alarms in your mech vent. The high pressure alarm, the low pressure alarm, and the apnea alarm. Highlight in your exam. What if you cannot figure out what's causing the alarm? Let's say the alarm sounds on, okay, it turns on, you suction the patient, you check the connections, but still the alarm is there. What will you do if you cannot figure out what's causing the alarm? The rule of thumb, do not forget this in your exam. If you cannot figure out what's causing the alarm, the only nursing action is to do ambo bagging. You know, ambo bagging. Another term for ambo bagging is your manual ventilation. Please do not forget that. Manual ventilation or ambo bagging is the only nursing action if you cannot figure out what's causing the alarm. Okay? So that's it. So that ends my short video presentation or video clip. I hope you learned something. Thank you so much, and God bless everybody.